Hello, my name's Anthony Effinger, and I'm here today on the Think Neuro podcast from Pacific Neuroscience Institute. I'm talking to Dr. Howard Kraus, one of the founders here. Thanks for joining me.
Thank you, Anthony.
So tell me about your practice.
I'm a surgical neuro-ophthalmologist, and that requires some explanation.
Yes.
Neuro-ophthalmology is everything to do with the eye and vision that's not inherent to the eyeball itself. So problems behind the eye, in the eye socket, moreover problems of the brain, problems in the nervous system, or systemic diseases that affect eyes and vision. And surgical ophthalmology, surgical neuro-ophthalmology is the application of surgical techniques to correct some of those problems.
So you're the behind the eye guy.
Exactly.
Okay. And there's a lot behind the eye in the brain.
There is. Indeed, 40% of our brain is involved with vision. Not only the direct transmission of the visual signal from the eye to the brain, but then the processing of that visual information beyond the occipital cortex into the higher cortical regions so that we can logically make deductions about what we see in our environment and act on those deductions. And then there's a significant portion of the brain that's also involved in our attention and controlling our eye movements.
So tell me how you became a neurosurgeon specializing in behind the eye.
Well, although I operate with the neurosurgeons, I'm not actually a neurosurgeon myself. I'm a surgical neuro-ophthalmologist and have spent a great deal
Sure.
of time training and working with neurosurgeons. It's always interesting to look at our ancestry and our origins. At the turn of the century, my grandparents immigrated to New York City from Hungary with little in their pockets except the name of a cousin or a family friend that would vouch for them and take them in so they didn't require being on public assistance. So my parents were first generation, and my parents were Depression babies. So unfortunately, their education was truncated, as a consequence of which there never was very much money in the family, and I grew up in a public housing project in the Bronx. And my father quickly made it evident to me that as soon as possible, I needed to find means of supporting myself. So college wasn't required, but it was an option if I could pay for it. I had a natural proclivity toward mathematics and physics and a natural interest in the universe and science fiction. And I was a kid during the era of the beginning of the U.S. manned spaceflight program.
Sure.
So at age 12, both by economic necessity and interest, I determined that I would be an aerospace engineer. I thought that I would go to the City College of New York, but I was fortunate enough to gain admission to the Cooper Union, which is a small undergraduate
Sure.
institution in New York City.
Highly regarded.
With schools just in engineering, art, and architecture. So I obtained my bachelor's in electrical engineering while I lived at home. And I was fortunate enough to do well enough at Cooper Union to earn 2 semesters of support at MIT, where I got my master's degree in aeronautics and astronautics, and then immediately sought employment with the Hughes Aircraft Company in Los Angeles.
And moved west.
Yes. So I arrived in Los Angeles.
From the Bronx and New York City.
From the Bronx and Boston, knowing no one.
Boston.
Knowing no one. And my initial term with the Hughes Aircraft Company was in the Missile Systems Division, but then I spent a year and a half in space and communications designing spacecraft and satellite communication systems. All along, as a young 22-year-old getting to explore Los Angeles, 3 weeks after my arrival in LA, I was introduced to my wife. And I convinced her to support me while I considered going to medical school. So we married 3 weeks before I started medical school. While I was working in engineering, I went to UCLA Extension in the evening to take classes in biology and organic chemistry, which I didn't have as an engineering major. But when I entered medical school, my principal interest was the brain.
What changed in your mind about going from a Hughes aircraft to the brain to?
Well, although I loved the academic challenges inherent to engineering, and in the short time I was an engineer, actually accomplished a few significant things, I determined that there was something missing. And that missing factor was something humanistic, something which touched people. And I've been very satisfied applying my thoughts and my skills to the direct assistance of people. And I can't think of anything more satisfying than the career that I've had. And while a medical student, I discovered that 40% of our brain is involved with vision. Found that to be very intriguing, and determined as a medical student that I would be a neuro-ophthalmologist. There are two ways of becoming a neuro-ophthalmologist. One is the medical neurologic track and then doing advanced training in neuro-ophthalmology. The other is the ophthalmology surgical track and then doing advanced training in neuro-ophthalmology. And even still, most neuro-ophthalmologists in the United States, which number about 400 to 500 today.
That's all.
Most of them are diagnosticians and not necessarily surgeons. There are perhaps 100 surgical neuro-ophthalmologists in the nation. So following my residency at UCLA, I then took fellowship training at the University of Pittsburgh, which at the time was the only surgical neuro-ophthalmology fellowship training program where the training was with the neurosurgeons, with the ophthalmologists, with the head and neck surgeons, learning all of the appropriate skills to effectively operate behind the eye. And that's what I've been doing throughout my career.
When you say surgery behind the eye, that sounds complicated and a little scary to a layperson like me. Can you describe how one does surgery behind the eye? What it was like when you got out of med school, and what it's like now? Because I imagine it's changed.
Well, the major changes have been in the advancement of diagnostic techniques. For example, in medicine, decades ago, the word surgery used to be preceded by an adjective called exploratory. We don't know what's wrong with your brain, but we're going to do exploratory brain surgery.
I don't want that.
So if you look at the technologic advancements of first CT scanning and then MRI, the quality of imaging that we have today makes it unnecessary in most cases for anybody to have any kind of exploratory surgery. And even in the surgery behind the eye, there were times where one would have a surgical procedure to go behind the eye to remove a tumor and to discover, well, it wasn't a tumor, it was an inflammatory process. So the first breakthrough in surgery behind the eye, as well as surgery in general, has been the use of these diagnostic tools so that one knows exactly before surgery, or as well as possible, what lies ahead, and one can plan the surgery. The next advancement has to do with Dr. Kelly's advancement in what's called minimally invasive surgery. So Dr. Kelly and Dr. Griffiths in combination have been doing a great deal of transnasal, minimally invasive brain surgery. So
going through the nasal cavity.
Right. So it's interesting to note that perhaps as much as 50% of brain surgery nowadays is done through the nose.
And that was how much? I mean, 10 years ago, it was far less.
Yes.
Yeah.
So the way in which medical advances come about is a combination of both technology and experience. And some of the technologic advancements that have allowed minimally invasive surgery are the continued development of better endoscopes, where one can use a illuminated tube to gain a view of something inside a deep dark channel without having to make a large opening and bring a microscope in, as well as what's called neuronavigation, so that one can do MRI or CT scanning prior to surgery and place a detector on the patient's forehead in the operating room, and then have probes that will show you in different planes of view on a projected CT scan or MRI scan exactly where your instruments are. It's kind of like a GPS of the brain while you're doing the surgery. So being able to visualize structures in difficult to reach areas through endoscopes and being able to know with great certainty what the location of your instrument tips are allow one to do a more effective surgery with smaller and smaller openings.
And that means less damage to structures around.
It means less damage, less risk, faster recovery. So Dr. Griffiths and I in 2001 were the first in the world to begin to harness those technologies to go through the nose to the region behind the eye in what we call the orbit to remove tumors by a totally transnasal endoscopic route.
Okay, so before that, how did people do it? To remove a tumor like that from behind the eye?
Well, it depends. If you look at the history of orbital surgery,
Okay.
probably the earliest orbital surgery was done by brain surgeons.
When you say orbital surgery, you're talking about surgery on the eyeball?
Well, the orbit anatomically is the eye socket.
Okay.
So the eyeball occupies 1/3 of the eye socket, and then there is muscular tissue and fat and nervous tissue that occupies the rest of the eye socket. So there are some people who have the misfortune of having problems behind the eye that may require surgical intervention. So the earliest pathways of surgical intervention were by the neurosurgeon taking off a section of the skull from above the
Oh
eye
boy.
and then opening up the eye socket and then gaining access to the
So
eye
so
socket.
like a hole in your forehead?
Right.
Do you remember the first transnasal surgery you did to get to tumors behind the eye?
Very well.
Yeah. What was that? I mean, that had to be.
You know, everything is a history of thinking and process development. So if we look at endoscopic surgery, it's really the sinus surgeons that produced some of the early advances in endoscopic surgery. And the development and use of an endoscope dates back perhaps 100 years. But then as...
How so?
Well, just, people thinking about how to
Get in
get
there.
an image of something, up the nose.
Okay. So it was the, you said sinus surgeons.
Sinus surgeons were the first to make use of medical endoscopy.
How interesting.
But what's more interesting than that is that the use of the endoscope preceded the availability of neuronavigational tools. So in
So you're
particular,
flying blind in there?
well, I wouldn't say blind, but in particular in the face of someone who's injured or the face of someone who may have disease with potential erosion of bone, as is often the case with any new surgical technique, there were what we call therapeutic misadventures. So sometimes the sinus surgeon would find him or herself in the brain, or
The
sometimes
sinus surgeon would find him or herself in the brain. Didn't want to be in the brain.
that's right.
Got there by sort of wandering off the path.
Well, just not being familiar with the territory
I see.
and not having navigational tools. And similarly, there were times where I was called to the operating room urgently because a sinus surgeon had found himself or herself in the eye socket, and there was damage to the muscular tissue or the optic nerve behind the eye. So
What years are we talking here? When this is
that is
what decade?
that's the late 1980s, early
Okay.
1990s.
So that's when the endoscope becomes more widespread for sinus surgery.
Yeah, so what was called the FES procedure became very popular, which is functional endoscopic sinus surgery.
And what were they trying to fix?
A variety of nasal diseases, largely chronic sinusitis, polyps,
Oh, interesting.
deformities of the nose, which were preventing adequate drainage of the sinuses and leading to chronic recurrent infection. So functional endoscopic sinus surgery was a great boon, but in the early days, it also was something that would sometimes have terrible complications.
Therapeutic misadventures.
But it's interesting that a surgeon at the University of Pittsburgh named Dr. Joe was one of the first neurosurgeons to say, aha, if the sinus surgeon gets there by accident, why can't we get there intentionally? So neurosurgeons began to use the endoscope as a tool to access the intracranial space, initially for the treatment of pituitary tumors, but ultimately as the techniques were refined for treatment of a variety of tumors at the base of the brain. At the same time, Dr. Griffiths and I had been collaborating since 1990 in a variety of different surgeries for trauma and inflammation and cancer. Then I was at a international North American Neuro-Ophthalmology Society meeting in the year 2001, and one of my colleagues from Seattle had brought down the imaging study of a patient of his who had a very small tumor at the very back of the eye socket that was compressing the optic nerve beneath the optic nerve. And he was very frustrated because his patient was losing vision. And he said, I sent this patient to my neurosurgical colleague, and the neurosurgeon said, it's not safe to approach this tumor from above because it's underneath the optic nerve. And then I sent this patient to my oculoplastic colleague who said, well, it's not safe to...
Oculoplastic?
These are ophthalmologists who then train in plastic surgery of and around the eye tissues.
Okay.
And also do orbital surgery. And he said to me, my oculoplastic colleague said that this would be too dangerous to approach laterally because there's too much risk of damage to the small nerve fibers that control eye movement.
So no going in from the side here, from the side of your
for this
temple.
particular tumor, both the neurosurgeon and the oculoplastic orbital surgeon had determined that the risks of surgery doing greater damage were too severe to warrant removing this small tumor that was causing progressive damage to the vision. So basically, at that time in 2001, this patient was left in a circumstance where the source of his potentially blinding condition was known, but there was no effective, safe surgical technique to reach it. So as he circulated the scans around, having already had the experience of approaching the orbit transnasally with Dr. Griffiths, I said to my colleague, send him to us, we can fix this. And when the patient came down from Seattle, we told him, the surgery that we propose for you has never been done before, but we think it's likely to be successful. So because Dr. Griffiths and I had already been operating together for 11 years, we both approached this with great confidence, not with trepidation, not with anxiety. We were very confident that we would accomplish something that would be vision-saving for this individual. So there's a certain level of excitement and anticipation, but there certainly wasn't any fear or anxiety.
Was one of you driving the camera and the other the other devices? Is that how Dr. Kelly described that teamwork?
Well, although we are multiple surgical specialists working collaboratively, to some degree we respect one another's boundaries. So Dr. Griffiths, as our ENT head and neck surgeon, is the master and the supervisor of everything inside the nose and the sinuses.
Okay.
Dr. Kelly, as the neurosurgeon, is the director of anything that enters the intracranial space, even if Dr. Griffiths is holding the camera. And when we go into the orbit, I view myself as the one in charge of the other side of the bone and the other side of the periosteum in terms of instrumenting the orbit.
Periosteum?
Periosteum is a thin fibrous layer that lines bone.
Okay.
And it serves as a anatomic structure, which is a boundary between the nasal cavity and the sinuses and the tissues of the orbit.
So you have you each have your own area,
right? So
inside the head.
So just as
when you're working, it's like, this is my
exactly
territory. Okay.
Right. So we'll work together, and we may place instruments in one another's territory, but we respect who's in charge when we cross that landmark.
Interesting.
So for Dr. Kelly, it's the dura.
The dura is the tissue that surrounds the brain.
Exactly. So,
okay.
so
that's his.
So if the dura is opened, then going beyond the dura is Dr. Kelly or any one of our neurosurgeons' domain. If the periorbita is opened, then I'm in charge.
That's you. That's
But we work together collaboratively, and although the nose is a relatively small region, we can put 4 different instruments up the nose
so I've heard.
all at the same time.
Yeah.
Yes, Dr. Griffiths typically is holding the camera, and he has an incredibly steady hand. And then we will work together to instrument the orbit and safely remove tumors from within the orbit. Dr. Griffiths does have one advantage over all of us. And that is that if he sees any one of us doing something that he thinks might be dangerous, he can pull the camera out. So, so he has the ability to stop us in our tracks.
Interesting.
And actually, even though we are respectful of one another's territories, we're always talking to one another and coaxing and coaching one another. And it's interesting that having worked together collaboratively for so many years, essentially looking at a video screen to see a projection of what our endoscope sees. As an observer may enter the room and look at the instruments coming in and out, an observer might have the impression that two instruments are being held by the same surgeon in left hand and right hand, because the instruments are working together so well. But actually, in some cases, one instrument is held by one surgeon and the other instrument is held by the other surgeon. I liken it to a mind meld.
That's amazing.
Where we know inherently what our surgical goal is and what is safe and what is unsafe. So although multi-specialty is a great boon to providing the best possible patient care, developing a team where the specialists are accustomed to working together is key as well. And you reflected earlier on what it was like to do something that hadn't been done before, but recognize that apart from the fact that we take baby steps along the way, we also have a wonderful anatomic dissection laboratory. So very often before any patient has something which hasn't been done before, we'll spend some time in the dissection laboratory doing the planned surgery on a cadaver before we'll necessarily do that in the operating room.
Now, when you say we have that, do you mean the Pacific Neuroscience Institute has that?
Yes, we've got a wonderful anatomic dissection laboratory.
Where is that? Is that in?
It's in the John Wayne Cancer Institute, funded by some very philanthropic donors through the St. John's Health Center Foundation. We've been blessed that in our program development and in our research that many members of the community through the St. John's Health Center Foundation and other foundations have provided funds to support facilities and research, and it allows us to do many things that we couldn't otherwise afford to do.
So if I agree to leave my body to science, that's something that might be used for.
Absolutely.
Okay, well, I'm all in on that. It's all yours.
Thank you.
So, just coming back to that first surgery, you're in there, you see this thing. Did you remove it completely? And did you save this man's vision?
Yes.
Yeah.
And in his case, it was removed completely. But in our series of surgeries that we've done, not all of them are necessarily benign, completely removable tumors. So we've also approached cancers by this route. But even in the absence of being able to complete a surgical cure, we can debulk the tumor, remove enough of the tumor to take the pressure off the optic nerve, allow restoration of vision, and then sample the tumor to be more specific in terms of the nature of the tumor and other therapeutic modalities that may control the tumor, whether they be radiation or chemotherapy. So even in a case that is not surgically curable, the surgery can still be very helpful in treating the disease.
Certainly. So talk to me about, given that the brain is so devoted to vision, the vision and the eye must be, as you said, a window into the brain. Talk to me about how you're using that to diagnose other problems in the brain.
This is not a new concept, but it's a concept that is surprising us in many ways. So, over 100 years ago, it was recognized that if somebody had a brain tumor, that could increase the pressure in the brain cavity, and it could affect vision through a mechanism of what's called papilledema, which is swelling of the optic nerve as a consequence of increased pressure inside the head. So for over a century, ophthalmologists have been able to look in the eye and see optic nerve swelling and say,
Through the eye.
aha, this patient must have a brain tumor.
Interesting.
But as we have developed new technologies of looking in the eye, we're discovering some interesting surprises. One of the great advances in the last few decades is the development of what's called optical coherence tomography, where we can get very high resolution cross-sectional optical images of the retina.
Tomography, that means...
Well, tomography is like a section.
Okay.
So if you hold up a projection of a optical coherence tomogram, which is purely a cross-section of the retina determined by optics, to a adjacent histologic slide, which is studied as a cross-section of the retina in a deceased person.
When you say cross-section, you're talking about a picture here.
Well, a cross-section in general is simply a cutting and looking at something
Right.
in the depths.
Okay.
So you can do a cross-section of the earth or a cross-section of anatomy.
Right.
But when we're looking at it, we're looking at it pictorially.
Sure. You're looking at a picture of this.
Right.
Right.
So the resolution of a optical coherence tomogram of the retina is very similar to the resolution that you can obtain in a histopathologic specimen, where you might section
Okay.
the retina
Actually
of a-
section it.
right, of a deceased person,
Right.
and look at the two images together,
Yeah.
and you would be amazed at the ability to discriminate different layers of the retina. And the retina has the consistency of saran wrap. It's a very thin, diaphanous material, and the total thickness of the retina is about 250 to 300 microns.
Is the retina what we see? What is it?
Well, the retina is analogous to the film in a camera, although
Okay,
most cameras
okay.
don't have films anymore, they have
Well,
chips.
yeah.
So it's where the image is projected that comes into the
Into
eye.
the back. It's at the back of the eyeball?
It lines the back of the
Got it.
eyeball. Actually, it lines more than half of the inside of the eyeball. So the retina is our first visual sensing structure. And what's interesting about the retina is, apart from the fact that there are 100 million light receptors in the retina, is there are several layers of neural tissue within the retina itself that begin to do image processing and image analysis long before those signals get to the
In
brain.
the eye.
And then there are about 1.2 million cells that sit on the surface of the retina called retinal ganglion cells that bring that processed visual information through the optic nerve and then connecting it what's called the lateral geniculate at the base of the brain, and then projecting and coursing through the temporal lobe and the parietal lobe back to the occipital lobe at the back of the brain, where the image is first received by the brain. So when we look at the retina, we're looking at several layers of tissue, but
Several layers on this piece of
within
saran wrap.
within this very thin structure that is about 1/4 of a millimeter thick in total. But we're able to define the different layers of the structure. So we can look at the OCT, which is the optical coherence tomogram, and discern which layers are the retinal nerve fiber layer, which are the axons or individual fibers of the optic nerve, which layers are the retinal ganglion cells, which are the cell bodies of those nerves, and we can measure the thickness and look at the quality of those structures. So once we were able to do that, we discovered that what we can discern from these OCT images is more sensitive than what we can discern simply looking into the eye, even with digital photography of the eye.
How do you get the tomograph? Does it take a picture through the eye, or is it's a
It's
scan of your brain?
It's a scan of the retina.
Scan of the retina, like in a MRI sort of.
No, it's much simpler and much faster. the individual simply sits at a machine that's about the size of a toaster, and you look into an optical device and you look at a crosshair, and within seconds to minutes, the study is done.
Okay.
With just a little bit of
Okay. You get the picture.
just a little bit of light and no harmful or untoward
No.
sensation.
Do you have to do the eye drops that dilate your eyes and make
No,
you
none of the above.
walk into buildings afterward? None of that.
No,
Okay.
just
All
look
right.
just look into the machine. So not only are we able to use that one image in terms of diagnosis, but we're able to take sequential images over time to know whether or not the structures are swelling or whether or not the structures are atrophying. And there are several interesting things that have occurred as a consequence of this. One is it allows us to discern changes inherent to the retina, but moreover changes inherent to the visual pathways of the brain that had not been detectable before. And if we look at the resolution by which we're detecting change, it's sensitive to changes of plus or minus 4 microns.
4 microns in these structures in the retina.
Yes.
Okay.
So if you can discern a change that's plus or minus 4 microns, understand that the thickness of a red blood cell is 5 to 7 microns, and that the change we're looking at in an MRI to determine whether or not a tumor is growing or responding to treatment is plus or minus 500 microns. So we can see changes to a much smaller degree that allow for earlier diagnosis and earlier intervention than if we're simply following something on an MRI.
So this is just a much clearer, much better source of information.
It's better in some ways, but I wouldn't say that the OCT replaces the MRI.
Okay.
But the OCT is a tool that can be used in conjunction with other diagnostic tools in the MRI. So it's a useful adjunctive tool, if you wish, that is much more sensitive than simply relying on the MRI. But there's another really dramatic breakthrough that has occurred because of the availability of this technology, and that is that it disproved a 100-year-old dogma. And the 100-year-old dogma in neuro-ophthalmology was that if something happened in the brain behind what's called the lateral geniculate, or behind where the optic nerve makes that first synaptic connection to the rest of the visual pathway, if something happened in the occipital lobe or the parietal lobe or the temporal lobe that may have affected vision.
Where vision is processed.
Right.
Where we were processing the information from the...
Exactly.
Yeah, okay.
The dogma
And the optic nerve.
The dogma of neuro-ophthalmology was that change would not be reflected or discernible in the eye. But as we began to do optical coherence tomography to measure the thickness of the retinal ganglion cell layer, it was discovered that indeed the corresponding retinal ganglion cells that would correspond spatially to where vision had been disturbed by an occipital lobe or parietal or temporal lobe stroke or tumor. Or process, that was reflected in the eye.
Because it changes somehow in response?
Well, it used to be thought that the visual pathway was a one-way street. That light would be sensed, the signal would be sent from the retina to the optic nerve, connected at the base of the brain to the visual pathway, and that there was nothing coming back the other way. So
no information, no
information,
synaptic.
no transmission of anything.
Because it had done its job. It got the information there. And
but we do know that in terms of the health and integrity of nerve pathways, that sometimes information or molecules flow the other way to sustain the viability of the detecting nerve. And OCT, by demonstrating that there was retinal ganglion cell atrophy in the retina, even if the disease were more distant in the brain, demonstrated that there must be some kind of retrograde transsynaptic transmission of information or chemicals back to the retina, and that once the region of the brain that was responsible for sensing that region of the vision was no longer viable, that indeed there was a die-off of the corresponding retinal ganglion cells in the retina.
Fascinating.
So what this has opened up is a whole new area of research where we're hoping to be able to use the OCT to detect and study changes in the brain that may or may not be progressive over time, but moreover, changes in the brain where we might be able to do something therapeutically to improve brain function. Most of neurosurgery and neurology nowadays is designed to prevent greater damage. And we're just on the threshold of trying to develop interventions to rewire the brain, to improve nerve connections in the brain, to regrow the brain. There's a lot of hope in research areas of being able to reverse some of the damaging effects of MS, some of the damaging effects of dementia, Alzheimer's disease, and Parkinson's disease. So imagine, if you will, that as we're applying these therapies, we need to figure out whether or not they're working. Well, one way is to do neurologic testing, to do cognitive testing, and then to try to quantify those things with MRI and to sense whether or not your interventions are effective. But imagine if we could look at the retina through a simple scan
Sure.
and see whether or not the health and integrity of the retina is improving. Since nowadays we only see a one-way path of deterioration, imagine if we can reverse that and detect that very sensitively by analyzing the retina. And moreover, if we look at the nature of retina, we can say that retina is brain. There's a lot of similarity in the nature of the retinal tissue and in the nature of brain tissue. So whereas people may have spinal fluid studies to look for tau protein or beta amyloid as an indicator of Alzheimer's,
Okay.
why can't we develop optical scanning devices that would allow us to discern the chemistry of the retina without having to put a needle anywhere to draw a sample?
All you do is sit in front of the machine that's the size of a toaster,
Right.
get your image, and this tells
So-
you. This
so-
can tell you about clues about.
Well, the
possibly-
OCT presently shows you the anatomy, shows you the health and integrity of the retinal nerve fiber layer, the retinal ganglion cell layer, the very fine blood vessels of the retina. It doesn't yet tell you the chemistry. But I'm hopeful that research will enable us to discern the chemistry of the retina and allow us in a less invasive way to know more about the nature of disease, the diagnosis of disease, the progress of disease, and more importantly, whether or not our interventions to try to reverse disease are effective by doing these retinal scans.
Because less intervention is always better.
I believe so. We try not to cause too much pain and discomfort to our patients, but every interventional procedure
Sure.
also carries some risk to it. So the more we can be very specific with a less invasive surgery and a less invasive diagnostic technique, the better care we can provide for our patient.
So does this have you? Does this new these advances? Do they have you working more close? It must have you working more closely with doctors here who work on these other conditions.
Well, the beauty of this institute that we've built is its devotion to a belief that having doctors working closely together, both physically as well as in overlapping areas of diagnosis, intervention, and research, will allow for a greater rapidity of advances and more direct applications of our combined skills in the care and treatment of patients and their diseases.
There's this, this whole field in management theory now that the people you meet in the stairway are every bit as important as having a meeting with your boss or whatever it is. These formal meetings, the informal interactions, these chance encounters are often where innovation happens because you're mixing up different specialties, different disciplines, right?
And I certainly believe that to be true and have seen that to be true. And our patients are not always, from across the street. Sometimes they're from thousands of miles away in this nation or other nations. And if they can come to one building, as they often do, and see 4 different specialists and have an MRI scan on the same day and meet with a collection of us to talk together about their problem and the ways to approach it, I believe that they get a much higher quality of care.
Yeah, and certainly especially if you're coming from far away, we've heard about patients from Pakistan
Sure.
and everywhere. If you can come here and get this done in one trip, that's
Sure.
valuable.
I had one patient relate to me at the end of her long day of seeing multiple doctors and having another MRI scan that what we accomplished for her in that one day was better in her mind than what she was able to accomplish spending 1 week at a very famous university medical center. And one of the problems with large centers is although they may have all of the specialists, they're often in separate geographic areas on campus. It's hard to coordinate getting from point A to point B. There's no central coordinator in most cases who's arranging all of the visits in an efficient fashion. And all of the specialists don't necessarily work in a close collaborative fashion. So they may interact with one another on the electronic health record, but may not speak to one another on the phone or may not see one another.
Well, and may not see each other in the stairwell,
Right.
where valuable things happen.
Correct.
And you probably don't have to fill out the forms over and over, do you? Here,
I hope not. I hope not. We are in an era of forms and electronic data inputting. So one of the things we endeavor to avoid is unnecessary duplication, but I'm sure it's something that we still need to constantly work on.
so tell me what other conditions you think might have some light shed upon them by OCT.
Well, I think it's unlimited because we've learned that OCT is a direct mirror image of functions and disorders and diseases that may occur in the brain. So if we look at the top list, we already know that it helps us in terms of diagnosis and the management of tumors. We're beginning to recognize that it helps us in the diagnosis and management of multiple sclerosis. And we're hopeful that it's going to help us in early diagnosis and management of other degenerative diseases such as Parkinson's disease and Alzheimer's disease. But really anything that affects the brain, whether it be problems with blood flow or stroke or inflammatory disease or tumors, anything that affects the brain should be discernible either by structural changes in the retina, which we can see on OCT, or by future technologies, which hopefully will be available soon, by optically scanning the retina to determine the chemistry of the retina. If we can optically scan the atmosphere of Venus and discern that it's 96% carbon dioxide and that it's got neon and argon and krypton and the variety of other elements in it, why can't we scan the retina and understand the chemistry of the retina without having to put a needle into anything to draw out a fluid sample?
Tell me about some of the referrals you get here.
Well, earlier I had mentioned that one of our patients for the transnasal endoscopic image-guided orbital tumor surgery was a economics professor from Helsinki. The reason he sought us out was he also had one of these small tumors at the back of the eye socket underneath the optic nerve. And Finland has a wonderful national health service where you can get anything that you need at little to no cost, but it has a limitation of what's available. So he was offered a transcranial surgery to go around and under the optic nerve.
Transcranial, tell me, that
brain
sounds
surgery.
like they're going to cut a hole in his head.
Right. And the concern there is not the excessive nature of that surgical approach, but that it's an unsafe surgical approach to go underneath the optic nerve and engenders significant risk to vision itself by taking that surgical route.
It's an unsafe.
To go under the optic nerve by a transcranial approach.
Why? Just because you can't get a good
As
angle on it?
a general principle, if you have to go around structures, especially
Okay.
to the opposite side of a structure as delicate as the optic nerve, that there's a lot of risk in that approach.
Okay.
But nowadays we have the internet. So this highly educated professor chose to do a little bit of research before accepting the referral that he was provided. And he discovered that there are places in the world where this is approached by means other than brain surgery. and he sought us out. One of the interesting things about Finland's healthcare system, although it's a wonderful system, is not only can you only have what they have, but if you need something or want something that's not available in their system, they won't fund it. So he paid out of pocket to make his travels, make his lodging arrangements, and have us operate on him. But we also made it very affordable. So even for those who cannot find what they need to have done in terms of a minimally invasive surgery, we have the ability to help those individuals make those surgeries happen.
You're willing to work with him on his
Right. Now, in some cases, we also have to look at hospital costs, which we don't always have direct control over.
Right.
But in general, we do whatever can be done to provide the necessary care and treatment of people that either can be subsidized by their healthcare system if they have that available, or subsidized by insurance, or hopefully in many cases can still be affordable for them.
That's fantastic. How did the surgery go for him?
It was great. One of the most satisfying things about what we do is that sometimes we see the benefit in the recovery room. And it's very dramatic when someone goes into a surgery with significant problems with their vision.
He had significant, what were his symptoms?
It was a progressive dimming of the vision of one eye because of the pressure on the optic nerve. So, we think of it as, what we're expecting to see in the melodrama of a 1930s black and white film. But indeed, some of our patients in the recovery room will tearfully say, "I can see again." And I can't think of anything more satisfying.
Oh, I can't imagine. Yeah. So he recovers. He comes out from anesthesia and says, "Wow, I noticed a difference already?"
Yes.
That's tremendous.
It is.
Yeah, that's tremendous. And how long was his stay?
Well, Dr. Griffiths and I have perfected this particular surgical technique such that it's outpatient. The endoscopic equipment, the neuronavigational equipment, and the ambulatory surgery center. And these surgeries will take anywhere from an hour and a half to 3 hours, depending upon the complexity of the tumor. But then the patient goes back to their hotel room or back to home within a couple of hours of the surgery. So the other advantage of a minimally invasive surgery is that the recovery is faster. And although we're still reluctant for people to have outpatient brain surgery, I think that in the not too distant future we may see outpatient brain surgery as well.
That would be an achievement. Yeah. Because the less time you spend in a hospital, the better, right?
As a general,
as a general
that's what they
principle, tell me.
Yeah, unless the food is very good.
Yeah. How often is that the case?
I haven't heard it yet.
That's tremendous. That's a great example of a referral, but
right.
And you probably get a lot of those, right? People are finding you. They're finding.
But apart from people finding us on the internet, one of the values of our developing this collaborative team and working together is our success is not a secret. So there are many physicians in the community who refer patients to us. So one doesn't have to do a internet search to find us. Many physicians know of the work we do, and each of our patients become emissaries, if you will.
Sure.
And relate to their own communities, their great success in having obtained care here at the Pacific Neuroscience Institute.
Dr. Cross, thanks for joining us. This has been fascinating. Thank you.
Oh, you're welcome. Have a great day.